For those who don't know, my name is Kelly Caulfield. I'm the executive director of the Common Sense Institute. We are a nonprofit organization, we are a nonpartisan organization, and we are dedicated to the protection and the promotion of the Colorado economy. Before we get started, I'd like to share our board of directors. We have a great board that directs a lot of Common Sense's work, and I would ask if there's any Colorado board members or national board members, could you please stand and be recognized? Common Sense Institute did 90 reports last year. We're very busy, and we do that with 10 bipartisan policy fellows. We'll be hearing from Greg DeArgon, our newest fellow, who focuses on healthcare for us, but you can see here on this slide, we have experts focusing on housing, crime, economic mobility. They are resources to the community. If you have places where you would like fellows to speak, please get in touch with me, and we'd love to have them come to one of your next events. I also want to have the research team here wave your hand. Common Sense has a small and mighty research team. Please raise your hand. We have a team. They're here. Thank you for your work. Before we get into today's program, I did just want to take a moment to talk about what Common Sense has been up to. It's not even March yet, but we've produced 10 reports. Our work is simply not being read, but it's being acted upon. And so far, this legislative session, we put up some of our favorite pictures. We've been busy sharing our research with policymakers. We do not lobby. We educate and inform, but it's important to make sure the legislature and other policymakers understand the latest data and trends. Just today, actually, a few hours ago, Tamara Ryan, our Economic Mobility Fellow, was presenting childcare data and trends to Democrats and Republicans in the Senate Education Committee. So that was a great experience. And just a few weeks ago, we were up there talking about our latest human trafficking report and housing report with the leadership with both Democrat and Republican members in our Colorado General Assembly. Our voice is really growing louder in the public square. In February alone, CSI earned over 300 media mentions through our op-eds and earned media. At this point, I really want to thank Colorado Politics and Luigi Del Puerto for partnering with us today for this great program, and I'll be introducing him in our panel shortly. Before I do that, I did want to say that Common Sense has just relaunched our podcast, and it's called Common Sense Unfiltered. We have a fun little video that I want to share with you briefly about the new podcast.
Common Sense Unfiltered, where we talk common sense. Because as it turns out, it's not all that common.
I'm Katie Ratliff, Executive Director of Common Sense Institute, Arizona.
I'm Kelly Caulfield, Executive Director of Common Sense Institute, Colorado.
And I'm Cinnamon Watson, National CEO of Common Sense Institute.
Across the country, policymakers are making big decisions on complex issues that are often filtered through politics and partisanship. That's where CSI comes in.
We're nonpartisan, nonprofit, and focused on the facts. And each episode, we bring in the experts behind the research to break down complex issues and what they actually mean for your business, household, and family.
This is Common Sense Unfiltered, where common sense still exists, even when it's hard to find.
We just recorded our first episode with Common Sense Homelessness Fellow Dustin Zavanek. You can subscribe on the Apple platform or any other podcast platform that you're familiar with. So please consider joining today. And then finally, I wanted to preview our next event. We're doing almost monthly events here in this space. Common Sense Institute's first Eggs in the Economy, which is our early morning programming, will be on St. Patrick's Day. So you can come early morning at 7:30 to 9, and a very exciting panel. We'll have one of our economists talking about an annual report that Common Sense does called our Free Enterprise Report, where we track our competitiveness here in the state of Colorado relative to every other state and the District of Columbia. And a part of that conversation will be Sean Boyd from CBS4, longtime political reporter, will be moderating that conversation. She has a great show, I think it's called Left, Right, and Center. So we will be bringing along those two political analysts, Mike Dino on the Democratic side and Dick Wadhams on the Republican side, to have a great conversation about what the data means for the future of Colorado's business climate. So please consider joining us on March 17th. You can click on that QR code and register, or register on our website. I'd now like to introduce Greg Diargon, and I'll introduce him briefly, and I'm going to have him come up and provide some data and facts from his most recent study on Medicaid, which is really the topic for today. I think many of you all know Greg. He's been a wonderful addition to Common Sense's group of bipartisan policy fellows. He spent nearly 40 years in hospital management in a variety of capacities, and most recently was the chief financial officer for the Continental Division of HCA Health One. So we are thrilled that he's joined us, and I'm going to have Greg come on up and talk a little bit about his recent study. Thanks, Greg.
When Kelly said I spent 40 years in hospital management, I started out in the mailroom when I was 6. So let's see. We're going to talk a little bit today about the challenges facing Medicaid, and really more specifically to the point of the Department of Healthcare Policy and Financing, better known as HCPF. There's a lot of issues with Medicaid. There's a lot of issues with HCPF. We don't have time to talk about them all, but we're going to talk about a few of them here. And then I'm going to turn this over to Kelly and Luigi and our panel. Some of our key findings from our recently released report. You can see on here between 2015 and 2025, HCPF spending grew 101%. That doesn't include money spent on patient care. That's largely just administrative costs over that period of time, while the rest of the state budget only grew by 64%. So it far outstripped the growth that the rest of the state had, and in fact has now surpassed education as the biggest spend in our state. The Colorado Department of Healthcare Policy and Financing over this time frame spent $16 million. And we'll go into a little bit more of this, but we believe that they grossly overspent on non-patient care services and probably cost the state $5 million. Some key facts, shortening the time frame between 2018 and 2024, Medicaid enrollment grew by a little over 7%. Now, there were a lot of ups and downs. We had COVID in there where it went up, and then in the last 2 years, we've seen a significant amount of Medicaid disenrollment, patients leaving the program for a lot of reasons. But during this time frame, where Medicaid enrollment only grew by a modest 7%, HCPF's FTEs, full-time equivalents, rose by 78%, or 339 new employees. Also, HCPF spending from the director's office rose 100%. It basically doubled between 2018 and 2024. And again, this is related to non-patient care spend. It's administrative in nature. The next slide, and we'll talk a lot more about this as we go along, are some of our recommendations that are in our report. Consider rolling back some of the recent legislative actions that have increased costs. On a future slide, you'll see that over the last 5+ years, our legislature has enacted 182 healthcare bills over a 5-year period that our providers have to follow, that HCPF has to follow, so on and so forth. Many of these have questionable value for the constituency. and in many cases do not improve health care for our patients. Up at the top, take a better advantage of SDPS. This is self-directed payments. Could have saved the state millions of dollars if implemented in a timely fashion, and Maureen's going to talk a little bit more about that later on. And or reform the hospital transformation program. This was talked about in depth in the report. It's not creating value, it's not improving quality, and it's costing us money. It's costing providers money, not just hospital providers, all medical providers, and it has added a lot of overhead to HCPF as well. Return the full value of underpayments to hospitals when found in RAC audits. The RAC audits, it's really just a mess. We talk more about this as we go along. The RAC audits need to focus more on preventing and finding fraud than they do as opposed to taking money back from providers, all providers, not just hospital providers, for services that they rendered in good faith to our patients. More to come. And then lastly, more of an effort to keep eligible people on Medicaid. I talked a minute ago about how from 23 to 25, the Medicaid program has shed several 100,000 covered lives. And a lot of that is the fault of the Medicaid program post-COVID by making it so difficult to re-enroll in the program. This is a problem that other states have not had. So high disenrollment for Medicare leads to more emergency room visits for uncovered patients, less primary care, and poorer patient outcomes. Back in July, this study was done talking about how we were at a crossroads, and I'd like to just show one slide from that study, and I talked about it previously. We've enacted 182 new bills, and really, it's hard to find the value creation or the quality improvement related to an enormous regulatory burden placed on all providers and HCPF, and you can see how much it's costing the state every year. It's an enormous regulatory burden. So with that, I will turn it back to Kelly.
Greg, excellent work. Greg will be working with us throughout this year on additional studies. So really excited and really proud of this first research project. Congratulations, Greg. I now want to introduce our moderator and panelists quickly. The goal of this panel is to really unpack the data that Greg just presented. What does it mean to me? What does it mean to medical providers in our state? And what does it mean to the future of Colorado? While I introduce you, please make your way to the stage. Luigi will be our moderator today, and he'll be right beside me. He serves as the editor of the Denver Gazette and Colorado Politics. He is a veteran political reporter and award-winning journalist. He previously served as a publisher and editor in Arizona and has won numerous awards for his reporting. He's a fan favorite here. Thank you, Luigi, for joining us. I now want to have Alec Garnett, who doesn't need much of an introduction, to join the stage. Alec serves as the Vice President of Government and Regulatory Affairs at UC Health. He previously served as the Chief of Staff to Governor Jared Polis and as the Speaker of the Colorado House of Representatives. He has had significant roles in major legislation that has passed, impacting healthcare, economic policy, and tax, among others. And I just have to say briefly, when I moved to Colorado 10 years ago, I was just some lowly government affairs person, and Alec Garnett sat with me for probably almost an hour to have coffee with me as I talked about education policy in my last job. He's very wonderful, and I appreciate that, Alex, still. I want to bring up Maureen Tarrant to the stage. Maureen is the Vice President of External Affairs at HCA Health One. She's also a board member of the Common Sense Institute. She previously served as the president and CEO of Presbyterian St. Luke's Medical Center and Rocky Mountain Hospital for Children. She was a board chair of the Denver Metro Chamber of Commerce and was named one of Colorado's top 25 most powerful women in business. And then finally, I'd like to introduce Josh Hannes to come to the stage, a real rural expert. We're so pleased he can be with us today. He is a vice president at the Colorado Hospital Association. He previously served as a vice president for the Wyoming Hospital Association, where he played a key advocacy role on behalf of 29 hospitals across Wyoming. He also was in a senior role with Cheyenne Regional Medical Center. I'm going to turn this over to Luigi, and thank you so much, panelists.
Thank you, Kelly. Appreciate that. Can you all hear me? Are we all good? Oh, very cool. Thank you again for your time. Appreciate it. I always want to start with a softball question. So what do we have? We have, we heard from Greg, high disenrollment, high uncompensated care, poor patient outcomes, runaway costs, and as the reporting had shown the last week or so, billing fraud. So Alec, what happened?
Thanks, Luigi, and thanks, Kelly, and thanks to CSI. This is a great panel. I want to thank Greg for all of his hard work for this report. I was telling everyone how timely this report was with all of the challenges that the state is facing, both on their budgetary side, but also with some of the reporting that Seth has been doing at the Denver Post about some of the challenges within different service lines at HCPF. I also start
We don't mention the Denver Post here. I'm kidding.
Yeah, sorry. And I start many of these panels with anything that I was there for, I apologize for, because now that I have a much better understanding of kind of what happens on the outside, I think what's happened is that HCPF has had a director for 8 years who has started with a real focus on starving providers and hospitals in particular across the state, and focused primarily the policy portion of that title, healthcare policy and finance. It really should just be focused on Medicaid and running Medicaid as efficiently as possible, because that is the core responsibility of that agency. But instead, there has been an over-focus on trying to ratchet down whatever HCPF can do to punish hospitals. And it really has been a model of focus and punishment on hospitals that has led to a missing of the core perspective and the core responsibility of the agency, which is to run Medicaid to its most efficient and to its best ability for the most vulnerable in the state, and for the providers who provide the most care to the most vulnerable in the state.
Wow, starvation and punishment. I think we're off to a great start. Maureen, what has been your experience? Alec had talked about a framing or a framework coming out of our healthcare agency. How would you describe your experience had been the last decade with regards to Medicaid and spending?
Thanks, Luigi, and it's great to be here. It's great to be with all of you. I should tell you, as Kelly said in my introduction, I've been a hospital CEO for 22 years. And so I did get a chance to come out a lot and understand public policy to the degree to which I have had in the last 2 years when I flipped in my company to this VP of External Affairs. I knew I was challenged because my CFO would come into my office quite frequently and tell me that we had some bad financial news. One of those talking points that he would give me is, Greg talked about those RAC audits, recovery audit contractors, and there was a lot of clawing back of money that we had gotten paid by Medicaid. I'll tell you one other thing about that real quickly. So, your hospitals are complicated businesses, right? Medicaid is a huge payer in our state. And it is, as you said, Alec, it's for the most vulnerable. HCA Health One actually is the largest Medicaid provider in Metro Denver with 27%. But what we noticed is we were getting this money clawed back, and this RAC audit that's in Greg's report ended up learning that Colorado was the most aggressive state in the nation in terms of taking back money from hospitals. And my company does business in 20 hospitals. So when I was an operator, I knew there were problems, but when I was able to get outside and see the light and work on public policy, I'm going to try to be crispy here and say that I realized, to Alex's point, they don't like hospitals. Maybe they.
You mean the state?
HICPUF, like, so the governor, I will
Okay.
say the governor and the HICPUF director are very, very critical of hospitals, as if we are the reason for the overspending, and we're not. And we'll talk more about that.
Yeah, the CSI report said some $850 million in the costs that we have seen are the result of legislative changes. And Josh, I was wondering if you can flesh that out a little bit. What has that meant for you and your industry?
Yeah, so, as mentioned, healthcare is it's incredibly complicated and it's heavily regulated as it is, and Colorado seems to have taken a position over the last several years to make it even more regulated, and that takes time away from patient care. It takes investment that's not reimbursed in any way. They're unfunded mandates, really. So one good example is the HTP, or Hospital Transformation Program, which is a way to measure quality, and there's nothing wrong with that, with the exception that a number of programs exist already. A number of hospitals participate voluntarily in other similar programs. And what HICPUF did was they created a quality program where the metrics don't align with other similar programs. They're complicated to report on. And it's another example of a program being created at the state where they didn't go into these communities, and I'm going to speak specifically for the rural communities. They didn't go and ask these experts, what should this look like? Like, we want to make sure that quality is good. We want to make sure we're measuring it and improving on it and iterating on best practices. But they didn't ask those questions because those answers exist inside the hospital walls. Those people can tell you exactly, these are the quality metrics that we're concerned about and we need to do better on, and we should be measuring that. We don't have a problem with that. But they have not listened, and this program has been burdensome administratively, which again, costs money and takes time away from patients, because these are clinical people doing this work, and they're not at the bedside when they're doing this.
Is there, what I've heard from the three of you is that we got some major problems, and it seems to me please correct me if I'm wrong, it seems to me what you're saying is that instead of the legislature or the state capitol, instead of the state solving these problems, they're actually exacerbating them or creating new ones. Am I misreading that?
No, I think that's correct, and I think it happens frequently. And I mean, we're in session now, and there'll be pieces of legislation that come across, and some come well stakeholded, where legislators are asking the right people the right questions, and you're navigating that process. And there's going to be a healthy tension there, and there should be. But other times they are ideas somebody thought of on the way in, and they're not well thought through.
Alec, what happened?
Well, I think two things happened. One, Medicaid, the legislature, by passing one bill at a time, turned the Medicaid benefit program into everything for everyone. So all of a sudden, Medicaid has become one of the richest benefits in the entire marketplace. So if we were all on Medicaid, you probably would have a better benefit than you would on commercial insurance. For example, Medicaid today covers equine, music, and physical therapy. These are areas that are nice to have, and if we had all the money in the world and you didn't have to constitutionally balance a budget on an annual basis, may make sense. But that is not the world that we live in. And as Medicaid has expanded into 30% of the state budget, instead of HICPUF utilizing their responsibility of managing the program and saying, that's a very nice thing to have, however, we can't afford that here in Colorado. We want to make sure that the benefit covers the most important things like primary care, and we want to make sure that it covers the most number of people. But there's been no management or leadership from HICPUF to intervene in the legislative process to say we can't have those 189 bills building out the Medicaid benefit program to be the richest because we as a state can't afford that. And on top of that, HCPF has been mismanaged. HCPF, as Greg pointed out, their FTE have grown 70% since 2018. To put that in perspective, the number of people on Medicaid in Colorado has decreased since 2018 by 5%. But as the agency has expanded administratively, the cost per enrollee has increased. So in 2018, it cost $13,000 to essentially cover somebody on Medicaid. This year, it's increased 46% or 48%, and it's up to $27,000 per enrollee per year. That shows an expansion of the benefit, then that shows an expansion of the agency to a point where it's unsustainable. And how did we get to this place, and why hasn't the executive branch and the legislative branch done a better job of containing the costs until now?
Maureen, Colorado has historically not taken advantage of what's called state-directed payments. And although these SDPs have been available, and a lot of states do take advantage of them, and they've been available for like a decade now, or more than a decade.
2016.
2016, yeah. We didn't take advantage of this. What is this program, and frankly, why should the people in this room care?
So I'm going to talk about state-directed payments, but I want to put a data point to Alex's comments about where the explosion in costs have come from in Colorado Medicaid, which is now the biggest line item in the budget. We're all taxpayers, we care. So 5% of the 1.2 million Medicaid recipients in Colorado account for 45% of the expense that is now in the budget. And we're not talking about because they're sick and they've had long-term stays in hospitals. These are all the programs that Alec was talking about. And you see a lot of TV ads, actually. If you ever watch some daytime TV, and when I babysit my 2 grandsons, I get to do a little bit of that. But there's ads on television for how to take advantage of these free Medicaid services. And so that's the part of the budget, this now top line item in the budget that's out of control, long-term services and support. Let's talk about state-directed payments. I didn't know what this was until about 2 years ago. So in the United States, since about 2016, every Medicaid program in the United States could take advantage of maximizing matching federal funds. And Colorado is now one of 6 states that have never done it. So this year alone, we finally got HCPF probably on the last possible day, right, Alec, to apply for this state-directed payment program. If we get over the finish line, and I think we will, that'll be worth $470 million into the state of Colorado. But you multiply that over the years since 2016, and you're talking of billions of dollars that were left on the table by Colorado.
Wow.
One, I just want to sort of add to that. I think it's really important because it goes back to this, what I started with, which probably sounded a little harsh on the punishment side. But the fact that HCPF never took advantage of maximizing that federal drawdown, in my opinion, was to make sure that those $470 million on an annual basis weren't flowing into providers to help cover the Medicaid population, because there was a philosophical viewpoint that hospitals should not get that money. But it has disproportionately set Colorado back from where we could have been. And to do state-directed payments like most states have done, like Maureen pointed out, and many, many, many blue states, they have moved to a managed care model. And the managed care model helps set a ceiling on how much state general fund dollars or taxpayer dollars go into managing Medicaid. And they contract with private entities to work with Medicaid patients to contain those costs. And by doing that, the state's general fund isn't on a runaway train, and you're maximizing the federal drawdown. And the important thing to remember is that if we had done that, like all these other states have done, we would not be in the budget situation that we are now. And all of the waste, fraud, and abuse that you're hearing about, like in the emergency medical transport program that expanded in a 4-year period by 436%. Okay, I don't know any, I don't know anywhere that has expanded that much. It is because it is a fee-for-service, volume-based service line. So if you are a medical Medicaid transport provider, you contract with HCPF, and then you just send in your receipts on where you are transporting the Medicaid patient to their doctor's office, and there was no check or balance on whether or not you were complying or if you were following the law or if you actually took that Medicaid patient to that doctor's office, or maybe did you go to Wyoming and down to Pueblo and then out to the Anschutz campus? No one was watching that. And so, but if you were in a managed Medicaid model, there would have been a contract, there would have been a private entity managing that service line, and that explosive growth would not have been able to happen. But instead, HCPF wanted to keep it all in-house, and when you keep it all in-house, no matter how many FTE you bring in, there is going to be opportunities for these areas to explode, and that's what happened, and the taxpayer's on the hook for that.
Josh, the legislature is in session. What would you like them to do?
Wow, I have a list. I think at CHA we've said going in recognizing the very serious nature of the budget, and the first thing we're asking people is to do no harm. Right, we are already suffering. 84% of our rural hospitals, again, just rural hospitals, have an unsustainable margin or have a negative margin. They can't afford additional cuts to reimbursement, which are already insufficient. So ultimately, what we're saying is we are suffering now, and I want to make clear there are rural hospitals in the state today having conversations about what service lines they have to close and how long they can stay open. This is very real. It's not in the future. It's happening as we sit here. So if you leave with nothing else, please leave with that. But in terms of your question, baseline.
Yeah, 1, 2, or 3. What should they do? Like right now, what can they do? And rather, what should they do right now?
Right. So there's around regulation. We talked about that at the very beginning. Let's relieve these programs and things that aren't benefiting hospitals. They aren't benefiting patients. Let's make sure, to the extent possible, that Medicaid, like Alex said, gets back to basics. Their function is to provide coverage, healthcare coverage, for a certain population of people. They need to get back to that. Those are a couple things I think we would start with. Don't harm us, and to the extent you can cut other places that aren't benefiting patient care, reinvest those dollars. I think that would be the best we could ask for.
Go ahead, ma'am.
Yeah. So I know that the governor's office has tried to paint hospitals and doctors as the problem. Because most of us, when we think about overspending in Medicaid, we probably think about hospital costs, right? Well, interestingly, in Colorado, 18% of the Medicaid budget is spent on hospitals. The average in the United States is between 30 and 32%. So trust me, hospitals are not the problem. So Luigi, what I would tell the legislature is, first of all, get real with this. Hospitals are closing. 73% of them have a negative or almost negative bottom line. And by the way, we're also huge economic engines for our communities, and we're safety nets in most of these communities that we serve. So first thing is get back to the basics that we've all talked about in the Medicaid budget. And interestingly, the folks who run Medicaid in Colorado, HCPF, they have had slide deck presentations they've given to say our spending is out of control. And so our state budget director has said, you're right, we got to cut this stuff back. So number one is listen to Mark Ferrandino and cut this stuff back. We have to. It's terribly unfortunate. Number two is don't cut hospitals. There's a proposal on the table right now for 3.9%. There are hospitals that will not survive if that happens. And then don't fund some of these extra administrative programs that cost money. I'll give you one data point that's shocking. This hospital transformation program, which is duplicative of other quality programs. Trust me, we're one of the most regulated industries on the planet. If you don't think people are coming in to look at our quality all the time, then we haven't communicated what we're committed to first and foremost. But That hospital transformation program, just to comply with it, cost my hospital group $1 million, just to hire staff to comply with a program that doesn't do anything. So
You're talking about paperwork and
I'm talking about hiring staff. These are nurse leaders who have to go in and look at all the metrics that the state has decided they want on top of other metrics to penalize us if we don't meet them. So get rid of that stuff.
Alec, I'm not going to ask you what the legislature should do. You've been there. You've been with the governor's office. What I want to ask you is, how do you lobby the legislature to get these things done?
Well, I start with saying I'm sorry if I was there for any of the for any of this, and then yeah, all right, I deserve that. But it's funny. It didn't take me very long on the outside to understand where the state was getting stuff wrong, and I think it's important to point out that during COVID there was a federal health emergency in place so that everybody that was on Medicaid didn't have to go through the re-enrollment process on an annual basis. There was essentially a 3-year pause on anyone having to re-enroll in Medicaid as a way to make sure that during this pandemic, everyone was getting, the most vulnerable were getting the coverage that they needed. When the health emergency ended, each state had to go through what they called a Medicaid unwind, where as the Medicaid rolls expanded, they had to go through and make sure that everybody on those rolls was still eligible to be on Medicaid. Colorado had one of the worst Medicaid re-enrollments in the entire country. There was 537,000 Coloradans that were disenrolled from Medicaid. And in some states, even red states like Florida, there was a white glove handoff if you didn't qualify for Medicaid into the individual exchange. But Colorado didn't do that. And so those people fell through the cracks. But they still have health needs, and they would still show up to hospitals, and our uncompensated care started going much, much higher. So at UC Health, we're the #1 Medicaid provider statewide. And 1 in 3 Medicaid patients goes through UC Health. And that's like 1.2 million discharges on an annual basis. Our uncompensated care went up $100 million because at each emergency room across our system, there was a double-digit increase in the number of uninsured patients showing up to get care. That in and of itself is just an example of how the state wasn't doing their job to work with providers statewide to make sure that the most vulnerable were being cared for. So as you go in and talk to the legislature now, what we're saying is the governor's budget that was proposed this year is really targeting healthcare. And they're saying things like Medicaid's expanded by 11.9%, and it's on a runaway track, and it's growing too much, and we really have to cut it. But they did a study with an independent group called MNAT, which is a healthcare consulting group nationwide. And MNAT came back and said, hospitals are not the problem. These service lines, emergency medical transport, long-term care, behavioral health, and autism care have all exploded by over 100% within HCPF. And you have got to get those under control in order to get the state budget under control. And so what you lobby the legislature on is that is hard work. Getting Medicaid back to a sustainable place where the most vulnerable are getting their most needed care and it's not impacting and pushing out other state priorities is going to require an enormous amount of work and trust. And right now, there is zero trust with HCPF. We cannot go sit at a table and have an honest conversation about what Medicaid should look like because there is no trust anywhere in the system. And we've got to get back to the basics and build out that Medicaid program. But that's going to take time. So don't balance the budget this year on the backs of Medicaid patients because we need a little bit of time to figure out what a sustainable Medicaid looks like with a new administration. And so therefore use the tools at the disposal of the Joint Budget Committee, reserve, unclaimed property tax fund, lots of other big funds, state education fund, and let's use the resources that are there to find a responsible way to balance the budget this year and buy us some time with a new administration to build trust and figure out how Colorado is going to move forward.
Josh, is there anything that our current regime has gotten right? Is there any policy that seems to be working that you'd like to keep and not have the state legislature, sorry, Alec, mess up?
Well, I don't know that there is, if I'm being frank. I think Alec described pretty well the situation we're in and what needs to happen going forward, which is quite frankly a wholesale reevaluation of their purpose and mission and what that looks like. So, I think it's important to bring up, and I know you didn't ask this question directly, but one of the things, not something they're doing right, but the Rural Health Transformation Program was part of the HR 1, and so it was the $50 billion that was directed to states, and Colorado got $200 million this first year. That's great, except, as I discussed before, this is a situation where HICPUF did not talk to the rural providers that are eligible to receive these dollars. They created a plan and then released it. They wouldn't share it with us. Ahead of time, we saw it when it was publicly available on their website after it was submitted. And there's a number of things in there that don't have a chance of improving rural healthcare. So what will happen is hospitals, providers of different types won't participate in those programs. The money will sit, and at the end of the year, the federal government will swoop that money back. That is a huge missed opportunity and a completely unforced error. There was opportunity to sit with providers who could use these dollars to stabilize their operations. And yes, there's CMS rules and there's restrictions and it's hard, right? But you sit with people that know what they're doing, that have to implement these programs and are accountable for the outcomes, and have them co-design with you. They did not do that. And unfortunately, in my short time in Colorado, it's become obvious that's how they do business. And so that needs to change.
So here's what's been reported the last week, in case you haven't read from the Denver Post, although I'm not going to mention the Denver Post. It's a good reporting done by one of the reporters who used to work actually for the Denver Gazette. But here's what we found out. That Colorado used a flawed analysis to dramatically increase the cost of transportation billing. And as Alec alluded to, it's $6.10. Compare that to other states like Ohio, $1. Other places like Arizona, $2. Ours is $6. And the flawed analysis is that this, instead of your routine sort of non-ambulatory transportation, they applied the ambulance rate to this transportation rate. And so obviously it's going to be a lot more expensive. And so if you're growing by 4%, what that has meant is that 3 years ago, the cost was $70 million, and then it went up to $211 million, and now it's $300 million just from this one change alone. And by the way, it's also green lighted by the state legislature. Sorry, Alec. But so I guess my question is, how do you, of course, an audit's probably going to catch this, maybe not, right? But an audit happens after a year. And the legislature is a reactive body. They'll react, the next year. And maybe they'll fix it, maybe they won't. But so how do you ensure things like this won't happen?
Well, let's be clear. In my world, I'd be fired. If I was overseeing a program where the Uber driver was supposed to pick you up and take you to your doctor's office, and the going rate should have been $65. These are real numbers, $65. But instead, for all these years, HICPUF was paying these Uber drivers $650 to take you to the doctor. Now, that's quite a gig. That was the rate, to Luigi's comment, that an ambulance driver should have been paid, who needed to help you get out of your house into a wheelchair. You know what an ambulance looks like versus an Uber car. It's expensive. So not only did they not oversee this for all these years, what the article told us is that the ethics and compliance that was alive and well in the Transportation Association of Colorado. I might have gotten the words incorrect, but they wrote to HICPUF and said, you're overpaying us. They wrote to HICPUF 2 years ago. And that's basic, fundamental leadership question, right? Who gets, people, we all make mistakes from time to time, but to have no infrastructure in your own business, by the way, and this is the largest line item in the state budget, and you have that kind of mismanagement, that's not fraud, waste, and abuse, that's mismanagement. So if you have that going on in Colorado, and you still get to keep your job, you can finish that sentence as well as I can. I don't understand it. I don't understand it. And then, you can see I get very riled up over this. To actually make the statement, we need to go audit the drivers. Why? You gave them the rate. You told them, bill us $650, and nobody was watching, except the own industry, the transportation industry, who said, you're overpaying us, and nothing happened. So that's a problem.
Clearly, I'm in the wrong profession. I should have started my own company, and there's an election that's happening this year, obviously, and what would you recommend the next governor do? Let's just start with Josh.
Yeah, so I mean, a little bit selfishly, I'd say that there needs to be investment in our rural healthcare infrastructure, particularly hospitals, which are the anchors. And it's not just send money, it's you send money because we want to care for people, right? We want people to be healthy, to be productive. There's an economic development argument to be made. Money invested in rural communities returns itself many times over. Hospitals in rural communities are often the largest employer. You know, school districts are often up there, county employees, but they're major employers and major economic drivers. Businesses aren't relocating to places without hospitals, and they're not relocating to places without hospitals that say you can't do general surgery. We need to make significant investments so that these communities can thrive, people can access healthcare close to home, which is where people want to receive their care. They don't want to travel. I spent a number of years working and living in Wyoming. I had to come to Denver sometimes, right? And I'm so glad it was here for me. But if I can get it at home in my community, that's where I want to be. And so we need to make sure that we are prioritizing. I think budgets are a reflection of priorities. State budgets should reflect, you know, if you care about these communities and the health of the people that live there, then let's talk about that and let's make it obvious.
Yeah, and if you missed our Rural Reckoning series, which we wrote about the problems and the policies and their impact on rural Colorado from a couple months ago, let me know. I'll work with you and get you a subscription to Colorado Politics, okay? Ma'am,
Yeah.
recommendation for the next governor?
Well, that's on my mind a lot. And here's some good news. We actually have 50 states in this country, and some states run Medicaid really well. And we're going to start studying that. I've made a recommendation to CSI that let's make part 2 of our healthcare report best practices so we can give the governor a template of what right looks like.
And the Governor Alex is going to take it, and the legislature is going to go out. This is awesome. We're going to pass it, and that's going to be the first bill in 2027, right?
Well, I mean, I think what I would say is everyone's focused on affordability. You hear affordability on the left, you hear affordability on the right. If you want to save people money in the healthcare space, if you run Medicaid to the best of your ability, you will do that. The state's sole responsibility in the healthcare arena is to run the best Medicaid program you can. If you run the best Medicaid program you can, and you're drawing down the maximum federal dollars that you can, and you have as many people enrolled on Medicaid as you can, then our uncompensated care number isn't going up $100 million. 1 in 7 patients, or 7 in 10 patients, 70% of patients in Colorado are on Medicare, Medicaid, or TRICARE. Those are government-insured healthcare programs that don't cover the cost of care because the reimbursements are too low. The state has control over Medicaid. If you are doing the best that you can, then you're not just giving You're not just reimbursing 79 cents on the dollar. The states that took advantage of the state-directed payments were getting $2 on top of the dollar. Colorado was getting 79 cents on the dollar. The federal reimbursement rate for state-directed payments was $2 on that dollar. So again, if you are doing everything you can to maximize what the federal government will give you, if you're doing everything you can to keep people on Medicaid, which is going to be harder now that H.R. 1 passed on July 4th from Congress, because it's changed Medicaid enrollment in two very impactful ways. Instead of having to enroll every 12 months, you have to enroll every 6 months, and now there's work requirements. I hope that the state and the state legislature are holding HCPF accountable to make sure that our enrollment process is ready for these changes, because they were not ready for the Medicaid disenrollment and the Medicaid unwind. And that is what the legislature should be focused on. That is what HCPF should be focused on. Instead, HCPF takes their healthcare policy title very seriously, and they think they're kind of the healthcare experts in the world. And they come out with a lot of regulatory burden. They come out with a lot of reports that don't have buy-in from the stakeholders that the reports are on. And again, you're losing focus on the core function of what they're supposed to be doing. So the next governor, if you find a director of Medicaid who is an operator, you need an operator with an operating mind to go in and make sure that the administrative budget isn't going up by 101%, that the enrollees aren't going up 68% in the time that the next governor's there in office, and you can get the administrative costs under control, and then you can really focus on the basics of Medicaid. Instead of trying to roll out all these humongous ideas to change healthcare that's heavily regulated primarily by the federal government, in Colorado, which is a pretty small market compared to most other states with 6 million, if you just get your own house in order, you will save money on healthcare for people down the line.
Wow, you are asking government to be wise, efficient. You might be asking too much. Let's open it up to our audience. Yes, ma'am.
Please wait, and I'll hand you a microphone. One moment.
Thank you. Very excellent presentation. My name is Ramey Johnson, and I am a nurse. I'm a former legislator, and this is a subject that is actually near and dear to my heart. I have just a couple things to say and then a question. Number one, when I was on committees, I found that there were people, especially at that time when I was on the healthcare committee, that had no background in healthcare, and they really didn't know what they were introducing or even passing. Number two, I did work for CDPHE at one point as a surveyor or an inspector of nursing homes. And I found that there were legislators that were passing bills to affect CDPHE without ever coming to talk to us to see what was already in place, what we were already doing, and they were just muddying things up. So I know exactly what you're talking about, Alex. The third thing is I am on the Colorado Union of Taxpayers Board, and the last 2 years especially, there have been 2 and 3 bills every session that got passed that had 23 FTEs per bill. That's unsustainable. The last thing I'd like to ask, and it is sensitive, is how many of the people, or are there any, that are on Medicaid that are illegal aliens? Thank you.
Alec, do you know?
The legislature created a program that is sort of it's like it mirrors Medicaid.
You're talking about Coloradans for
Cover all Coloradans.
Cover all
yeah,
Coloradans.
so they created a Cover All Coloradans, which is essentially Medicaid mirror to provide benefits to anyone in Colorado regardless of documentation status.
Okay. Yep.
So an overarching comment, my name's Paul Archer. I own a business not far from here. We have 70 employees, and I have a business in Utah that has about 25 employees. Our healthcare costs here went up 30% in 2024. It went up 20% 2025. Healthcare cost in Colorado has nearly tripled since the implementation of the Affordable Care Act. So you're in an industry that's swimming in money, and you're pleading poverty, which is really kind of paradoxical to me. So my last question I want you to answer, I'm going to come back to a question for Alex, is what's your macro fix to healthcare? Because we certainly aren't on that path in terms of the cost of healthcare. Alec, you were the chief of staff to the governor, right? And Speaker of the House.
Correct.
So you said if we had done what other states have done, we wouldn't be in this situation.
Correct.
You said HICPUF has been mismanaged, it's bloated, it hasn't told the legislature what should be done. HICPUF is accountable to the governor.
Correct.
So the governor has completely failed in this situation, and the legislature has completely failed in this situation based on what you've told us.
Yeah, I mean, I think what I would say, because I don't think I said exactly that it had failed. I think it's important to put in perspective that state-directed payments and the management of Medicaid is very complicated, and it's taken me time outside in the healthcare space to really dig in deep on how Medicaid is flawed. And I think where everything has gone really awry is in the leadership at HICPUF. You are serving as the Medicaid expert, not just for the agency, but for the governor's cabinet and for the legislature. Well, I mean, I hear you. I mean, I think what I would say is when I was in the role of chief of staff, there are 20 other agencies, and there is a lot of issues that impact, you're the first call when a prisoner gets out, you're first call when there's a fire up in Thornton, you're the first call. So there's a lot of stuff, and you really do rely on, and I wasn't an expert in healthcare at the time, you really do rely on the experts that you surround yourself with on cabinet. And I will say that if I had known what I do now, my leadership in that role would have been very different.
Wow.
Yeah, I mean, the macro fix, I will just jump in and say, like, you can't do it in Colorado. You can't do it in a market of 6 million people. If there's going to be a macro fix, the federal government needs to lead on what it's going to look like nationwide. You can, again, you have to do what you're in control of here in the state. And the big swings that this administration has taken at healthcare, whether or not that's reinsurance or whether or not that's the Colorado option or just expanding Medicaid the way they have not worked. And so, again, I think it is hard to solve it. No state has solved it anywhere in the country in an individual state basis.
Thank you, sir.
I'll be very quick. And as an employer, you bring up an important point about your costs for your employees raising, and that there's a bunch of. I agree. Where I would push back a little bit is that where does that money end up? It does not end up, particularly in rural areas, at the point of care. You have insurance companies who are allowed to make money hand over fist, PBMs, device manufacturers, and hospitals care for everybody that comes in the door, regardless if they're insured or not. I think you and the business community can be excellent partners with healthcare to talk through some of what those challenges are. And Alex, right, a lot of those, the regulatory environment allows for them to do this, for insurance companies to not pay claims, for them to underpay, for them to delay payment. All of these things are allowed in the regulatory environment in which we live. And I think the business community, if they're willing, would be an excellent partner in raising the alarm on that. Because you're right, there is money there. It just doesn't go to the place it needs to be.
You mentioned this briefly, but it's a next disaster that's going to happen for ICPUF. as you pointed out, they're now going to have to document twice a year the eligibility. Now, we know HICPUF couldn't do this before when the re-enrollment, that multi-page application was extremely difficult and they couldn't handle it. And HICPUF has actually publicly stated that they need more people, more software, more hardware to deal with this, and this is going to happen in the next several months. How would you respond to that if you had something to tell them?
Maureen, go ahead.
So I've just been looking at this, Reggie, and there is a population in Colorado that's limited, that's going to be exposed to the twice-a-year eligibility. It's 347,000, no, excuse me, 370,000. So it's not everyone on Medicaid. There is talk about software that would allow the state of Colorado to expedite the 80 hours a month requirement for work. And there's a database that allows us to access information on your income. So I'm happy to tell you it's not everybody, but there are some tools that we can use to get this eligibility work requirement checked much more efficiently than we do today.
Greg, if you could speak louder, sir. Because maybe those other states might have solved some of these problems, is what you're saying. Okay.
So my question is, there's kind of two recommendations. One being, we have a lot of people on Medicaid. The costs are getting very high because of these plush benefits that you all went over, and there needs to be that needs to be reformed. The second thing is that we have uncompensated care, so we have to pay because people are not on Medicaid and are not paying. And I guess my question is if those plush benefits can't be reformed or legislators won't do it, et cetera, which one is more important? Keeping people off of, on Medicaid with plush benefits, or this uncompensated care that, Alec, you pointed out $100 million. But if we're pushing people onto a program that does still have that, which one is better?
Well, and I think that's probably an issue that HICPUF has struggled with, right? Where if they were to have managed the unwind to the best of their ability, and 537,000 people would not have been kicked off, the budget situation that we would be in now would be much worse. And so there is this sort of catch-22 from the regulatory perspective of how do you, what is the priority from the state? Is the state trying to make sure that the uninsured rate doesn't go up and that uncompensated care doesn't go up for hospitals, and that the frontline providers like federally qualified health centers aren't being really impacted? Or are they worried about the 30% growing and pushing out other priorities that they care about? I think from our perspective, we want to make sure that people have coverage, and we want to make sure, and the state has a lot of competing priorities, but from the broader employer and the broader provider perspective, we should want the uninsured rate to be lower than it was in 2018, and unfortunately it is not, and that is not a good thing. So we want people to be covered, and then the legislature across the board is having a hard time prioritizing anything, and I think that is primarily because
is that a fact?
You can throw stones at me all you want, but one of the problems has been, COVID was a huge problem because it flushed so much federal money into states.
Yeah.
And these legislators, these are just citizens coming in to serve. Most people out of the 100 that are serving now never served prior to COVID. If you didn't serve prior to COVID, you never actually had to balance a budget on just the state dime. You were flush with federal dollars that came in and went into long-term programs that created the structural deficit. But the one thing that should have happened...
You're saying that the state legislature took billions of dollars in federal money and used that to fund long-term permanent programs, knowing that in a few years, the money's going to dry up.
Well, yeah, whether or not they, again, you kind of budget in these one-year cycles. So whether or not they were making, whether or not those decisions were being made. But to Reggie's point, one thing that should have happened with those one-time dollars is they should have redone CBMS, which is the database that the state relies on Medicaid for. And what worries me most about this re-enrollment process coming up is that the state's relationship with the counties, which you have to rely on for re-enrollment of Medicaid, which is different than most other states, is not strong. And so it would be great for the next administration to have a HCPF who has the trust of the counties, because you need the trust of the counties to keep the re-enrollment process going as strongly as possible, and CBMS should have been reformed. But to Michael Fields' point, you have got to, the next governor is gonna have to set a table and figure out, does equine therapy need to be covered by Medicaid? Probably not. And so if it's not, then what are the core functions of Medicaid that must be covered for the most vulnerable in the state, and how can we do that in the most efficient and effective way possible that then makes sure that the state isn't disincentivized from making sure people were enrolled?
I think we have room for one more question.
First, good program. Thank you very much. Second, you've all referenced years of mismanagement. A simple question: where's the state auditor been?
And I think with that, that's a good place to end. Josh, Maureen, and Alec, thank you for your time. Appreciate it very much. I want to give it back to Maureen for closing remarks.
Yes. Okay, is this on? Can you hear me? Before we wrap up, I am very proud to be on the board of Common Sense Institute, and I want to thank again our fellow Greg DeArgon. Join me in a round of applause for him to do this report. So for those of you who don't know, we are a not-for-profit organization, and we rely on the generosity of concerned citizens like all of you to support our mission to focus on the data and facts and the issues that matter to most Coloradoans. There is a QR code. Oh, there it is. If you feel inclined to make a financial donation, which would be tremendously appreciated. So here's a few housekeeping details for you as we depart. Sign up for our newsletter if you haven't done so, and that's on that's on our website. Register for our next event, which will be on St. Patrick's Day, and that's a morning event, and it's the Eggs and the Economy, and you can also register on the website. Share our research with a business associate or colleague. Subscribe to our new podcast on a podcast platform, Common Sense Unfiltering. And then follow us on social media. Thank you so much for your engagement and your attention. So appreciate you being here.